Hello everyone, welcome to another episode. I'm joined by Daisy.
Hello.
To discuss a common and important presentation to the ER. Patients with chest pain who are at the same time hypotensive. But before we dive into the case, what are the major differentials we should keep in mind?
Well, right off the bat, we need to consider pneumothorax, chest sepsis, pulmonary embolism, aortic dissection, pericardial tamponade, and of course acute coronary syndrome with cardiogenic shock.
That's quite a list. Tell us about the case.
So, I saw a male patient in their mid-60s with a history of coronary artery disease and a pacemaker for complete heart block. He was hypotensive with systolics in the low 90s.
What were the other vitals in initial presentation?
His systolics were actually worsening to the 80s. He was intermittently spitting and coughing, pale and diaphoretic. He didn't have an oxygen requirement initially, saturating at 94% on room air. No obvious respiratory distress.
Interesting. Any signs of sepsis?
No. Temperature was normal. CRP was normal too. Just a bit of stress-related leukocytosis. When we did our initial assessment, the interesting finding was obvious global dyskinesia, particularly in the apex, as you can see in the video.
And the lungs?
Here is where it gets interesting. As you can see, there's bilateral pulmonary congestion, pretty consistent on both sides. The patient has no chronic respiratory conditions to mimic this picture, and despite the congestion, the lung fields sounded completely clear, even at the basis.
What about the pain characteristics? That can be really telling.
Well, the patient described it as someone standing on their chest, but simultaneously felt it between their shoulder blades.
Oh, that's concerning. Were you thinking about aortic dissection at this point?
Absolutely, especially when the patient became more hypotensive, dropping to the low 80s. We were in a bit of a bind. We needed to act quickly, but couldn't risk a CT aortogram, really.
And what did your initial workup show?
Well, labs came back with a troponin at 129 and a negative D-dimer. The chest film showed no mediastinal widening, but there was congestion and curly B lines, as you can see in the peripheries. The echo showed a normal-sized aortic root with no dissection flap.
Wait, you said you had a previous echo from somewhere, right?
Yeah, we somehow lucked out. We had an echo from 4 months prior showing normal cardiac output and ejection fraction of 60%. But here's really the interesting part. Despite all the congestion and evidence of failure, the BNP came back at 400, which is normal.
That's unexpected. How did that influence your thinking?
It was definitely confusing. We had to remember that aortic dissection can raise troponin too if it disrupts the coronaries. But weighing all the evidence, previous cardiac history, new myocardial hypokinesis, and elevated troponin, we felt ACS was more likely.
How did you proceed with management?
We got cardiology involved early, even before the labs were back. They reviewed our findings, including the non-diagnostic paced ECG. When we reported the normal BNP and raised troponin, they agreed with our diagnosis, but suggested local management.
How did the case evolve then?
The patient deteriorated. O2 set dropped to 80% on room air, increased coughing and spitting. We placed an ART line, prepared to give NORAD, and started IV morphine and furosemide. We also transfused 1 unit, given a new HB of 88.
And the follow-up?
In the ICU, the repeat troponin jumped from 120 to 500, and that initially normal BNP, it shot up to 1,000.
Wow, what a great teaching case. So what's your take-home message?
The key learning point is this. In cardiac sounding chest pain with convincing pulmonary congestion but normal BNP, you should really suspect an acute and evolving ischemic process. Sometimes you have to trust your gestalt and treat based on the best available information. Remember to involve the patient in your decision-making process.
This really highlights the importance of serial testing and clinical correlation. Thanks for sharing the case, Daisy.
Thank you for helping me break it down.
And thanks everyone for listening.
Thank you.